He's in the disciplinary honors. He's in the disciplinary honors track in the Lloyd International Honors College, and his presentation today is on structural violence, power structures, and public health education. Michael, you have the floor.
All right, thank you. Before we begin, I just want to apologize. My camera's down here, but the screen is up here. So if I'm switching between the two, I apologize for that. So let me share my screen. Okay, one sec. And let me go to present. All right, can everyone see my screen? Is everything good? All right, so as again, I'm Michael Ziga, and I'm presenting on structural violence, power, and health education. So my thesis for this is that I want to develop a better model to understand the social impact of the pandemic, specifically to create a more cohesive lens that merges sort of social analysis with more traditional public health models. So how it began? Well, over 1 year ago, I began a research project with Dr. Meredith Gringle about the socio-ecological impact of COVID. And I was curious about studying why public health officials and professionals had such a hard time understanding, predicting, and controlling the virus. In many respects, this pandemic is what public health was built for. Our discipline started as a way to stop the spread of cholera in the London sewer systems. Public health led the charge to eradicate smallpox and brought down infectious disease rates to historic lows worldwide. Ever since the 1990s, public health officials have been warning us about the potential for an earth-shattering pandemic. A book by Laurie Garrett called The Coming Plague, published in 1994, predicted the rise of a global pandemic, most likely a SARS virus, for the modern world. Yet as I did my research, it seemed that the pandemic caught us unawares. Even worse, all of our usual strategies, such as emphasizing social distancing and masks, did not seem to be working well as we wanted them to. Compliance was low and difficult to achieve. People became jaded with public health officials. Every day it seemed like our discipline was losing something important. So now I want to talk to you about sort of the state of public health education as it was when I was starting my research. One of the things that I noticed is that there's a large behavioral focus within public health education. This approach did not work well during COVID. First of all, what do I mean by behavioral focus? For the large part, public health focuses on changing the behavior of the individual. In public health, there are 5 theoretical models by which we can analyze the problem. Only one focuses on examining the larger social forces, the so-called socio-ecological model. Now, public health theory understands that the individual must be framed within the context of their environment. And there's a lot of literature about how structural forces such as racism and poverty affect health outcomes. However, this sentiment has not translated well over to on-the-ground action. I believe the reason for this is our theory understands that context matters, but it doesn't understand how power shapes those contexts. This revelation led me to a group of researchers who I would term social pathologists. Now, Dr. Wolf, George Wolf, in his article in the American Journal of Public Health, defines social pathology as the systemic doctrine demonstrating, as far as possible by quantitative means, the interrelationship between genuine pathological conditions, i.e. human diseases, in the clinical medical sense, and social conditions of the human environment. And that is a very complicated way of saying, okay, that what we need to understand is that instead of understanding health and disease from a purely biological lens, or let's say from just a purely social lens, we have to understand that, for example, a disease can often be a manifestation of, let's say, a power inequity or inequality within a society, right? So a disease is inherently tied to certain political structures and can be understood as emanating from those social, ideological structures within our society. Now, I would divide social pathology into 3 distinct parts. The foundation, I would say, is systems thinking. Now, systems thinking is an approach that tries to understand how a multitude of factors ranging from social, political, and psychological relate to one another. Now, the traditional models of public health, right, shape a problem as a pyramid with the government at the top and the individual at the bottom. But systems thinking would probably look at it more like a network with like different nodes being connected together with lines, and how they all interact with one another. And the reason that I believe that this is a more useful model is because something that I read in a paper by Dr. Shelley Golden in a paper titled Upending the Socio-Ecological Model. And she says that the socio-ecological model, or the traditional pyramid model, leaves the impression that these systems of power cannot be changed, that they are not inherently modifiable, and that it doesn't examine how these hierarchies are produced, maintained, or critically changed. Okay, and a system being defined as an entity with interrelated and interdependent parts working toward a common goal. Okay, so that's the first part. Now I think if we overlay, right, the historical context and the context of power over a system, we get what I would call structural violence. And they're basically systems of power and structures of power rooted within a historical context. This theory was developed by a doctor from Harvard named Paul Farmer, who recently passed away. But he basically said that there is that power seeps into our structures, and that sometimes this power is actually violent toward a specific group of individuals or a specific group of people. And for example, we could see structural violence in historical imperialism, racism, sexism, and classism. And what Paul Farmer says is that we have to understand disease and health not purely as cells interacting with one another, but pathologies of power, right? Diseases of power, and that these diseases are being caused by structures that are being violent toward certain groups of people. This really came up in my interview project, which I was part of my larger project that I did over the course of a year. And I started speaking with sort of nurses and frontline workers, and it was really shocking. For example, one of the nurses that I spoke to who worked at a senior living center told me that it was important to understand who was getting care, right? For example, when people were coming in and the hospital was being overwhelmed, she had an administrator tell her that that to turn away sort of poor African-American people without insurance, especially elderly people without insurance, and accept sort of younger, white, insured individuals, right? And again, I think that is an expression of how you can get, right, this structure that's failing certain communities, and how that is impacting disease. And also with the nurses that I was speaking to, they were telling me that that, for example, that they had no support, that they got some praise and they got some good words, but they didn't get the mental health that they needed. They didn't feel like their voices were being heard, and that was negatively affecting their health. And so how does that change the way we look at public health? Well, I think what we have to do is we have to start constructing a different model. And this social pathology, I think a part of it is what we call counter-hegemony, right? What does that mean? Well, hegemony is basically a power system. And what social pathology sort of works toward is the idea of building an alternate power structure that confronts the shortcomings of the current system and works for transformative change. Now, what does that look like in practice? What that looks like in practice is we go out, and instead of simply saying, accepting, right, this pyramid, accepting this hierarchy, we say, okay, we are going to build our own separate structures, right, such as clinics, homeless shelters, and educational facilities that can help address these shortcomings if the system is actively working against us, and if the system is violent toward us, or it's violent toward a group of people. And I think that you can see this during the civil rights movement, where there were survival programs, where they set up basically what we call food stamps. Basically, that there was communities that came together and organized like independent schools and clinics. And for example, that is something that I would consider a counter-hegemonic activity, right? It was done outside the purview of the traditional authorities. And additionally, I think you could say that there was the way the disability rights movement started in the United States was through a place called Camp Drew Ned, which is if there's a movie on Netflix called Camp Drew Ned, and about Camp Drew Ned, and specifically they talk about how these disability activists went out and started like this little camp where they could congregate and strategize on what they wanted to do, and that was I would say a counter-hegemonic theory. So ultimately, what I'm trying to get at is that when we look at COVID, we need to understand that if something's not working in a community, we need to go down. We need to have sort of a decentralized structure and really talk to the communities who are being hit the hardest, or who might not be responding to our measures, and interact with them and try to create a plan with them and ask them, here are the objectives that we're trying to meet. How can we help you meet those objectives? And I believe that can only be achieved through creating a sort of new social pathological lens. And that is my presentation, because I want to leave time for others. All right. I appreciate it. Thank you.
Thank you, Michael, for your presentation. So yeah, I see some applause there. Wonderful. Do we have questions for Michael? And feel free to unmute and ask them out loud, or you can drop them in the chat.
I have a question. If I can. I wanted to just know, you said that you were a senior, so would you like to work in this sort of systems thinking and rewiring of the public health education system, public health system as a whole in your career based on what you were doing with the study?
Oh, for sure, 100%. Yeah. I have like an internship going on right now, and I'm really involved with that. And hopefully I can continue that on in graduate school. This is like research that I'm really interested in. I'm really interested in like public health theories and things like that. Thank you. All right.
Any other questions for Michael or comments?
I have a quick question too. First, I just want to say I really enjoyed your presentation, and this kind of helped expand my thinking around public health.
I appreciate it.
And my question is just in the research that you did, I mean, hearing you talk about, where do we go from here, and how there's this history of alternative structures being put into place. Were there any that you encountered that were particularly inspiring to you, or that you feel like I want to do something like that?
Yeah, so I mean, there's definitely some of the stuff I was reading, like with like sort of, there was like during the civil rights movement, there were these survival programs where civil rights activists would go down and they would start like clinics and give out free food, like free lunches, and that they did that systematically. It wasn't just like one thing that they do like once every year, like it was a weekly thing. Or there was with Paul Farmer, who's a researcher that I was really reading a lot. Like he went to Haiti, and he had there was like really a lack of healthcare in the area that he went to, and he built like this flourishing hospital because he was working in these hospitals, and they weren't really like working, right? They weren't doing what they needed to do, and he sort of started developing this completely like alternative method of running these clinics and hospitals that really responded to the needs of the community, and like interviewed people on like, hey, what do you need in your community, right? So, and for example, that was something that I found, I don't want to speak too much, but one thing that I found was like when I was talking to people, like I'd be like, okay, how many times has like the healthcare sector come to you and be like, hey, what do you need? Like, what do you need in your community? Like, I don't know if you've ever had a hospital come up to you and be like, what does your community need? But I didn't find a lot of people who said that. So, thank you.
Thank you.
That was a great question, and I love the answer. I really appreciate the shift in thinking, hopefully to be more inclusive of folks and having them say what they need instead of people telling people what they need. So thanks for helping us think about that. All right. Our next presenter is Brianna Richardson, and she's a senior public health major and university honors student from Appalachian State University. She is a certified peer educator for a departmental organization called We Can, which stands for Wellness Educators for Change, Advocacy, and Student Needs, that is dedicated to the education and advocacy of student health through health topic presentations, events, and wellness campaigns. Brianna is interested in the impact of health education on health behaviors, the inclusion of intersectionality in health promotion, and conducting more public health research. And her presentation today is post-COVID-19 analysis of barrier method use and sex practices among undergraduate students. Brianna, the floor is yours.
Make sure that I unmute myself. Can everyone see that? Okay. Well, great. Well, thank you so much for that introduction. And I'm excited to be here again. My name is Brianna Richardson. I'm from Appalachian State. And this is my project, Post-COVID-19 Analysis of Barrier Method Use and Sex Practices among Undergraduate Students. So the background of my study is based in those aged 15 to 24 accounted for 55.4% of the sexually transmitted infection cases in 2019. So I wanted to do a study all about this, looking at undergraduates specifically, those traditionally aged between 18 and 24, or just in generally enrolled in college. But they're between the mean age of first intercourse at age 17 and first marriage at age 29. So this influences their diversity of sexual experiences, makes them more likely to be open and fluid and exploratory in their sexual interactions. And as we saw in that data, they're a high-risk group for sexually transmitted infections and unplanned pregnancy. So I wanted to do a study that analyzed these sexual behaviors. I did this study 16 months after the onset of the COVID-19 pandemic, starting in August 2021, and wanted to compare these to the CDC safety protocols. So my question was basically, how did public health guidelines and individually adopted precautions impact those in a lower probability of emulating sexually protective practices? So taking all of the mumbo jumbo out of that, I wanted to know if 16 months of being socially protective in the general public would subconsciously impact a high-risk group on their sexually protective practices. And I studied this with a anonymized questionnaire that I created. So just to give you a definition, a barrier method is a form of STI protection and or contraception that blocks fertilization and contact with sexual fluids without requiring hormones or professional administration for use. So you can see the methods that I used in this study here. So they're not the IUD or implant or the shot or the patch that you may know, but these are things that someone can buy at the store. You may need a prescription, but something that you can buy at the store and that you can use in frequency. So the American College Health Association's National College Health Assessment is a national survey of undergraduate and graduate students that just look at holistic data points, and some of those data points include sexual health. For their web-based survey in 2021, they collected data from over 70,000 undergraduate students and found that 3.5% engaged in anal sex, 35.4% engaged in vaginal sex, and 34.9% engaged in oral sex in the previous 30 days. But out of those interactions, only 5% used barrier methods with oral sex, 37.1% used barrier methods with vaginal sex, and 22.5% use barrier methods with anal sex. So basically just seeing that gap of how often barrier methods are being used among this group. So I based my survey, my questionnaire, on the National Survey of Family Growth. This is a CDC and US Department of Health and Human Services survey that's been in circulation since the 1970s. But it's just looking at general reproductive and sexual health of ever married individuals between the age of 15 and 49. Looking at their sexual behaviors specifically, what I was looking at with this questionnaire. But I wanted to use a peer-reviewed sexual health assessment in the basis of my study. And I compared it also to two entities at Appalachian State. So the Campus Wellness Assessment, this is something that is a biannual survey that's conducted under Wellness and Prevention Services on campus, looking at physical, mental, sexual, social, and financial wellness. I specifically use that sexual health data. And the Condom Ferry, which is a free barrier method distribution service on campus that has external condoms, internal condoms, dental dams, finger cots, lubricants, and other sexual health resources that are available for students, so they don't have to go into the community to be able to get these resources. And for the questionnaire itself, I specifically wanted individuals that were over the age of 18, were current undergraduate students regardless of their affiliation to a specific university, and that they had been sexually active in the previous 12 months before August 2021. But if they had not been sexually active, they still were able to do the survey. Just some questions were omitted after they interacted and indicated that they hadn't had a sexual interaction. And so I had a 52 questions questionnaire on Qualtrics, that software that just anonymized the data with lots of different topics. So you can see on the screen, that's just the beginning of the survey and one of the sample questions about barrier method use. But I had 243 individuals that interacted with this survey, and 124 of them had responses to some of the major sections that I wanted them to answer. So COVID-19 safety habits, so vaccination, hand washing, face mask use, sexual behavior, so if they had used a barrier method before or not, and barrier method communication with a partner that was monogamous or non-monogamous. And so I used Microsoft Excel to be able to do the analysis for this, but my alpha value, or what showed my statistical significance, was 0.05. So my first hypothesis was face mask use when unvaccinated would be correlated to the likelihood of using any type of barrier method when engaging in sexual activity in the 12 months prior to the administered questionnaire. This was too complicated of a hypothesis to do with a single test, so I had to make 3 research questions underneath that, which, as you can see, were accepted, rejected, and circumstantially accepted. And I'll have these on the other screen for you to be able to see. But the first research question was, among fully vaccinated participants, how did face mask use before and after being vaccinated change based on how many settings face masks were worn? So as you can see here, there was statistical significance with individuals wearing 5 masks on average before they were vaccinated, and 3 masks in 8 different settings after they were vaccinated. There was a decrease in the amount of settings that individuals were wearing masks, and I have the types of settings that were available here on the screen as well now. So some of them that were really interesting to me were those wearing masks at home with those not in their household changing so rapidly when they were unvaccinated versus vaccinated, as you can see on the top and the bottom, and those wearing masks physically distanced in an outdoor setting before and after, changing from about 26% to 7% here in their household, and 40% to 9.6% in that other setting, physical distance. And so for the second research question, I asked, did fully vaccinated status increase the likelihood of barrier method use in the 12 months prior to the questionnaires administration? So I wanted to know if someone had used a barrier method in the previous 12 months of that period of COVID, were they more likely to be a fully vaccinated person versus someone who was partly vaccinated, unvaccinated, or who just didn't indicate their vaccination status? This was not statistically significant at all. And so my third research question under hypothesis 1 was, is there a correlation between barrier method use and face mask use in settings with a higher likelihood of COVID-19 transmission? So out of those 8 settings that individuals could choose their face mask use practices that I gave, I had 4 that were the high risk settings. So these were at home with those not in your household, crowded in an outdoor setting, physically distanced in a poorly ventilated indoor setting, and crowded in a poorly ventilated indoor setting. But this was circumstantially accepted because only those in a crowded outdoor setting found some statistical significance with being in that setting and wearing a face mask and using a barrier method. So as you can see on top, it's pretty on average if someone was wearing a face mask in a crowded outdoor setting, and if they used a barrier method or not. But if someone was in a crowded outdoor setting wearing a mask, not wearing a mask, they were much more likely to use a barrier method than if they weren't. So that social and sexually protective comparison was in the inverse of what I was able to see. So just to give you some background for the final two hypotheses, there was an online college social life survey that was conducted in 2005 and 2011, which, though now over a decade old, it is some representative data. So between freshman and senior years, the odds of hooking up or having sex with a non-monogamous partner double. Condom use during a hookup decreases by half between freshman and sophomore year, that first and second year student, and condom use decreases when sexual partners attend the same college. So if you attend the same college, there's a lower likelihood that you'll use a condom with that monogamous partner. So hypothesis 2 was underclassmen status. So students that were in first or their second year would be associated with comfort in talking with a non-monogamous partner about barrier method use. So if you're having a hookup or having sex with a non-monogamous partner, would you be more comfortable talking about using a barrier method in that session? But this was statistically significant for upperclassmen. So in what I was saying earlier, between freshman and senior years, the odds of hooking up double and condom use decreases. But among those older students that were in their third, fourth, or fifth year, they were more likely to have comfort in being able to talk to that non-monogamous partner than underclassmen. So the hypothesis was correct in the opposite direction. So that was pretty interesting. And the final hypothesis was upperclassmen status, so third to fifth years, would be associated with infrequent use of barrier methods, and participants would indicate use sometimes or never. And this was rejected. Across the board, regardless of year or academic classification, it was basically just external or male condom use that was the majority of barrier method use. Only external, internal, and finger cots or finger condoms were present in the frequent use category. It was basically just never or or sometimes that individuals were using these. So there was no statistical significance between underclassmen and upperclassmen for this. But just in my conclusion, my discussion, I just want to identify that though this was available on social media and through an online campaign that I had, an email campaign that I had with 1,000 students at Appalachian State, there were a majority of Appalachian State students that engaged with this. And I understand the strictures that are present at our university in the community. Being in a small community, not wanting to go to a store that you may know everyone that works there to be able to get a barrier method for your first time or in your first time in that city. So that definitely limited some of that data that may have been alleviated in a different and bigger city. But for present and future research, I hope that this is used. I want to use it in my own future research and in the future of others on how we interact with undergraduates and educate them on how to access barrier methods and how to use them in general, to be able to just know about them. And I just recommend that someone use more qualitative data in the future to be able to get some more insight on why some of these data points were so interesting. But I'll be respectful of everyone's time, and these are my references, and I'll ask for any questions. But thank you for listening to me today.
Thank you, Brianna, for your presentation, and congratulations on actually having, what was it, 243 participants in a 52 question survey. That's quite a sample.
Yeah, thank you so much. Thank you.
Are there any questions for Brianna?
I have one question, and I apologize. There's a loud truck going by. I hope you guys can't hear it. But I do want to say that I'm very impressed by how in-depth your experiment was. So well done. And you mentioned a little bit kind of how you foresee your research potentially being used in the future. Is there any avenues specifically that you're interested in exploring, just as far as using your data to encourage safer sex practices on campus with college students?
Thank you so much for that question. I'm really excited to be able to figure it out in some sort of way to be able to use this research. But being able to work on campus, I was actually working for the Condom Fairy for a while that I mentioned, of being able to educate more people about beyond what an external or a male condom is, what is an internal condom? What are the uses for a dental dam? Things like that, once people know what they are, there's already an imminent increase of use, but also just being able to talk more about barrier method use beyond just using the pill and other things that are contraceptives, because people can buy these in stores or buy them online discreetly, and being able to just know more about them so they can have the choice to use them. Because I know that some of the limited qualitative responses that I was able to get had some, I've never heard of this before, that you can use that for oral sex or for whatever type of sex, that some individuals just didn't know about that at all. So I would love to, in my graduate studies, be able to work on a university setting to be able to integrate some more of that knowledge for these students to just know more. Thank you.
Thank you.
I have a question. Yeah, like, is there any sort of so what I understood was that as people go up, like as upperclassmen, condom use decreases, right? And so does that, like, in your research, does it seem like more that like underclassmen were communicating better with their partners about condom use, or like what was necessarily the reason that was driving those rates down at such a high rate?
So, so for that data, it was from the other study from 2005 and 2011 that showed that that stark difference in upperclassmen and underclassmen. And I sadly was not able to see that so much in this study. It was the inverse of more upperclassmen being able to talk to their partners about
Yes.
things like that. But it was, I would love to know a little bit more about that. With the amount of data that I wasn't able to show you, I did lots of different comparisons of those two groups and seeing why some groups may have had more non-monogamous partners than others, and being able to share that information, because a lot of the first year students just omitted some of those questions after they answered that they had non-monogamous partners, but didn't want to answer if they had used barrier methods or not, or if they used them for specific reasons. But I'm definitely wondering about that too, so thank you for that question.
Oh yeah, thank you. I just to make sure. Yeah, cool. Thank you. Yeah.
Thank you, Brianna. And so on to our final presenter today, Alexis Brown. Alexis is an adult transfer student who received her Associate in Arts degree from GTCC and is now a junior in the Undergraduate Social Work program at UNCG. She is passionate about advocacy in her work on and off campus. And Alexis' presentation today will be on urban agriculture, food insecurity, and gentrification. Alexis, the floor is yours.
All right, thank you so much for the introduction, Ms. Boyer, and I'm just going to pull this screen up real quick. All right, can you all hear and see me okay? I mean, not me, the screen, sorry.
Yes, you're perfect.
Okay, great. All right, so again, my name is Alexis Brown. I appreciate you all being here today. And I'm happy to share some of the findings from my research I did about urban agriculture, food insecurity, and gentrification. My interest in this topic grew from the 7 years I spent living in Philadelphia, working and volunteering on several urban farms and community gardens around the city, which I absolutely loved doing. And I was able to see and experience firsthand how impactful these spaces, as well as the food that they produce, can be on communities. But I also started to notice at times a disconnect between the mission of these urban farms and gardens to address food insecurity with their reality, including some of the projects that I myself was a part of. So that's what led me to this research, where I examined the role of urban agriculture in addressing food insecurity. And Sorry, you guys, give me just 1 second. As well as the ways that racial inequality and gentrification hinder the effectiveness of this movement. So I do look closely at Philadelphia in particular, given my own personal experience there, as well as the fact that 1 in 5 residents in the city faces food insecurity, and it's a place where urban agriculture is prevalent and on the rise. Here is my sister up in the front, and this is one of the many urban farms that I had the pleasure of working on in West Philadelphia. But to just sort of jump in, let's start by defining what urban agriculture is. It can include vertical and rooftop farming, urban foraging, community and residential gardens, as well as commercial urban farms that can be either for-profit or nonprofit. The most recent movement towards urban food production in low-income neighborhoods has been steadily increasing over the last 20 years, often filling land vacancies where industries have failed to address food scarcity, lack of economic opportunity, and the lack of management and care of vacant land. So in my research, I found that urban agriculture has the potential to improve food access by providing local, fresh, affordable produce, to create beautiful, safe outdoor spaces for children and adults, to provide educational as well as entrepreneurial opportunities related to food and health, and to connect and empower communities, and finally to address environmental issues through urban greening and sustainability. So my question is, can urban agriculture really affect food insecurity? First, let's define what food insecurity is. The USDA defines food insecure households as being uncertain of having or unable to acquire enough food to meet their needs. In 2020, 10.5%, that is 13.8 million US households, were food insecure. And studies show that while urban agriculture alone can't solve the overwhelming issue of hunger, it does have the means to be part of the solution. According to one study in Philadelphia, those actively participating in community gardens reported modest savings of $700 per family annually. And unsurprisingly, savings are greatest when these gardens are geographically accessible, meaning that they are situated within the neighborhoods where participants live. Distribution of fresh produce grown in urban environments is also increased through growers' donations of their harvest to food insecure families through food cupboards as well as shelters. So for example, City Harvest, a program developed by the Pennsylvania Horticultural Society in Philadelphia in 2006, which I myself have participated in, donates organic seedlings to 130 community gardens and urban farms across the city, which in turn donate a percentage of the produce they grow to over 150 local food pantries. Still, urban agriculture comprises a relatively small percentage of the overall produce distributed throughout cities. And more research is still needed to measure the impact on populations experiencing food insecurity. Something that is important to consider when looking at the effectiveness of urban agriculture in addressing food insecurity is that because these gardens and farms are still situated within the context of inequality that leads to food insecurity in the first place, the same inequalities can be built into the fabric of urban agriculture projects. So even while producing food in neighborhoods where there is a need and being able to distribute it effectively, elements of urban agriculture may still have a negative impact on the communities that they are intending to serve. So it's important to understand and avoid the potential pitfalls rather than considering only the benefits. In the journal Sustainability, researchers Signer, Sauerwein, and Acey caution us that, quote, without understanding the actual links between urban agriculture and food security, or which specific characteristics, models, or approaches reduce insecurity, urban policymakers and advocates risk backing policies that could have unintended consequences or negative impacts on vulnerable individuals and communities. Critically reviewing the pros and cons of the growing urban agriculture movement necessitates an honest acknowledgement of the racial dynamics therein. According to a national study from 2013, urban farmers are younger than the general farming population on average, more than half are women, and 91% of respondents reported being white. In the Journal of Agriculture, Food Systems, and Community Development, researcher B.M. Hoover points out that as urban agriculture works to undermine an industrial corporate food regime, it unintentionally creates an exclusive environment where people of color are excluded and where white privilege results in the control of land, food production, and any stream of financial capital. So the next question is, what gentrification specifically has to do with all of this? Gentrification is the replacement of low-income inner-city working-class residents by middle or upper-class households, either through the market for existing housing or demolition to make way for new upscale housing construction. Whether or not having outsiders move into the neighborhood to start urban farms results in displacement is still a topic in need of more research, considering the difficulty of methodically quantifying displacement. Nonetheless, there is strong evidence that areas ripe for urban agriculture are often on the front end of a neighborhood in flux, and the urban farms and gardens can themselves be the victims of gentrification. A 2018 study of urban agriculture in the US found that many urban farms formerly serving minority and immigrant populations have been forcibly closed due to development priorities for privately owned lots. In another study that followed 5 urban farms that had been in operation for at least 5 years in the Kensington neighborhood of Northeast Philadelphia, 1 farm had already been lost to developers and 3 others were struggling to fight them off. The only farm of the 5 not under threat is a commercial farm that was started in a mostly white, low-income neighborhood in Kensington that has stayed mostly white, but is now higher income, which has actually benefited the farming business. The other 3 farms being threatened by gentrification are not only fighting to stay in existence, they're also struggling to stay relevant amidst the changing demographics of the neighborhoods they serve, where food insecurity is no longer as prevalent due to the displacement of lower income residents. So in essence, gentrification has created an extreme barrier to the farms that were having the most direct impact on addressing food insecurity. So to summarize, there are no simple solutions, unsurprisingly, to solving the problem of hunger. And for urban agriculture to be truly effective, we must also address larger political factors that contribute to food insecurity, such as housing policy and land access, as opposed to simply focusing on growing more food. This research has helped me to reflect on my own experiences as well as mistakes and some successes as a young white transplant to Philadelphia who absolutely loved growing food and wanted to make a positive difference. So someone who really fit that profile of what we just learned about who urban farmers are. I wrote this paper a few years ago before I was in UNCG's social work program. So I'm now drawing new meaning from the data as a social work student and making new connections on how working to meet immediate needs of vulnerable populations has to be put in the context of larger social structures and systems of oppression. And I want to point out too, I noticed the connection with your research, Michael. I sort of came to the same conclusion that it's incredibly important to start off with questions. Like I might see a need as an outsider, but to be able to actually build relationships and to work with the community to say, what do you all need? How do you want to address food insecurity in your neighborhood? And especially what efforts are already happening that we can support and how can we best support you? While more research is needed to guide our way, we have the opportunity through urban agriculture to not only grow food, but to help steer us all towards food security, inclusivity, and justice. Thank you all so much.
Thank you, Alexis, for your presentation. Do we have questions for Alexis?
I do. Yeah, so I was just going to ask about, one, obviously I see definitely a connection between our research, and then also it's just like, first of all, how can someone get involved with like urban farming and something like that? And then second of all, like in an equitable way. And then second of all, could you recommend any further reading on this subject?
Those are great questions. Well, I would definitely point you to my bibliography, to my works cited page. So if there's a way I could share that with you, I would be happy to.
Sure.
There is some great research out there. And as far as how to get involved in an equitable way, so speaking from my personal experience, I think starting either in your own neighborhood or where you have relationships with people. So I think a big part of where these problems can occur is coming in again as someone who doesn't know the community, who doesn't have those relationships, and who's not really asking for input about, like, do you even want a community garden here? Are you interested in being part of it? I think often what happens is, you know, there's donations or there's nonprofits who will start a project and then try to get communities involved with something that they have already created, as opposed to having community input and buy-in from the very beginning of the process before ground has been broken. So I don't know if that answers your question, but.
Oh, sure. Yeah, no, and I'd love to look at I can send you my email like to get the further. Appreciate it.
Yeah, thanks for the question.
Thank you.
Are there any other questions or comments for Alexis? And while we're waiting, I'll also say UNCG has community gardens. I don't know if you knew that, Alexis, or if you've been involved, or anyone else who might be in the Greensboro area. And I think they're always looking for volunteers. Oh, Alexis, folks are interested in your work cited. So if you have a way to share that, please do.
Yes, I see, Michael, you put your email, and it looks like Priscilla, I'd be happy to email it to you too if you want to put it either in the chat, or you could direct message me if you want. Got it. Yep.
We have just a couple of minutes left until our session closes. I see we're joined by Professor Hassel. It's good to see you. All right. Just another minute or two for any comments or questions for our wonderful presenters.
I just wanted to let you know, I'm so proud of Allie. She is our boss at the Healing Garden at the Cancer Center, and she is absolutely phenomenal. And you should see, she knows the plants, she knows what works for the plants, what doesn't, and she's very passionate about this. And we're all such fans. She monitors and mentors all of us, and she is just such a superstar. And so I'm so proud of you, Allie. Good.
Thank you so much. Thank you so much.
Amazing. No, she did not tell us any of that. She was very humble. So thanks for coming on to tell us how wonderful she is. And as someone with a very brown thumb, it's wonderful to know there are other people with green thumbs who are out there increasing our beauty in nature.
Anyone can learn, truly. It's learned. Yeah. But
thanks for the encouragement.
Professor Hassel, she's like my biggest fan, and I just appreciate the encouragement. Yeah.
Oh, this is a beautiful love fest. It's a great way to end our session. It is 1:50, so I want to encourage you all to try to join some other sessions if you can this afternoon. And everyone is invited to the award ceremony at 4:30 today, where some winners will be named. So if you can make that. Portia, are you able to drop the link to the award ceremony for folks to grab? That's at 4:30.
And if you give me 2 seconds, I can
yes, sorry to put you on the spot.
That's
So make sure
okay.
that folks make that if they want to. So awards at 4:30. Just a round of applause again for all three of our presenters. This is not easy, especially in this format, and you all did a fantastic job. Thank you so much for joining us today. And thank you to our audience for being with us. And thanks to Portia Harris and the Honors College for hosting us today.